So today, why would we not want to talk about Parvo? We're going to talk about today. But I just want everyone to take a moment.
Oh.
It's Aaron Rodgers' 30th birthday.
Woo! I don't know who this person is.
He's the quarterback for the Green Bay Packers.
Yay, Aaron!
Yeah, you're the only one who's excited.
I know.
Happy birthday, Aaron.
I'm so excited. And hopefully he's playing on Sunday. His collarbone is healed, so everyone take a moment to wish Aaron a happy 30th birthday. It's a big deal in the state of Wisconsin.
All right. The only one I know about is Chiba.
He's just a big.
So welcome.
That's kind of old for a football player.
30.
He was on the 49ers. I'd be excited.
Whoa, 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 whoa.
If he was in me.
Okay, so one more thing to celebrate today. But let's talk about Parvo. So this was a study that was that they did at the Colorado State University Veterinary Teaching Hospital. It was just getting started there when I was doing my internship, which I did from 2010 to 2011. And what the reason they wanted to do a study is because they found, like so many diseases, especially this one because it tends to happen in lower income puppies sometimes, was to find another treatment protocol for Parvo. So this study is not yet published, but I did get to hear the abstract presented at ACVIM this year in Seattle. So this is the paper that is going to come out of it. It was done by a vet student and a couple of clinicians that I also was fortunate enough to work with during my internship. So like I said, it is not yet published. And I do not know the funding source of the paper yet. I have a feeling some might have come from Zoetis, as their drugs were used in the protocol, but I do not know for sure. So they wanted to look at this study because obviously they see a fair amount of Parvo at the VMTH, and sadly many puppies don't get treated. So they said, hey, let's see if we can come up with a successful outpatient treatment protocol to give clients who can't afford hospitalization to treat their puppies. So they wanted to look at the survival rate between the two groups. So it was a prospective case control study. These were actually naturally infected dogs. So these were dogs that came into the VMTH to be treated. And to qualify, they needed to not have a vaccination history. They needed to not be treated previously to presenting to the VMTH. They needed a SNAP positive, and then obviously their owners needed to consent. All the dogs, regardless of which treatment group they ended up with, they were treated with IV fluids with dextrose to support them cardiovascularly, and they got heat support. So everyone got that regardless, and then from there, they were randomized into the two groups, and they did it evenly, 20 dogs into each treatment group. And these are the two treatment protocols between the two groups. And when they did the enteral nutrition, what it was syringe feeding. They fed Science Diet AD, 1 ml per kg, 4 times a day. So both groups got that. The sub-Q fluids were 3 times a day. And then you could see they each got an antiemetic, Rhinia, Roptin, and then 2 different antibiotics. And one thing that I learned about this is the outpatients were actually treated in the hospital.
Oh.
They were not sent home with their people. Because I thought, I was like, really? They were asking owners to give sub-Q fluids 3 times a day, and they were cool with that? And so they were put into a different ward, and they were treated by hospital staff. But it was considered outpatient because they were not hooked up to IVs. They were in the, they call it the intermediate care ward. So, but all the dogs were, in fact, treated in the hospital. These are the parameters that they looked at from start of treatment until they were released from the hospital. So also, these were things that could be monitored when they, even as outpatients, were treated inpatient. But obviously it would be much harder, to say, an owner could do a body weight, and they could obviously look at the clinical signs, but they're not going to be running blood work. But you could teach them how to, look at hydration status, and, pain and nausea scoring might be a little sketchier. But these were the results that they had. they had a survival rate of 90% in the inpatient and 85% in the outpatients. And 3 of the outpatients did die. 1 just had to be moved to the inpatient group, but then that dog lived. So statistically speaking, there was no difference. And there were not any differences in any of the parameters either. No significant difference between any of the parameters that they were measuring between the 2 groups.
Interesting. So no significant difference, even though it looks like, inpatient was a little bit, but statistically it didn't come out.
Yep. So that was exciting. They were very excited for their.
It's really fascinating to know how many other protocols that we charge people routinely thousands and thousands of dollars for
could be done on an. Should we suggest that?
Well, an outpatient basis or even in an in-hospital basis where, like, the percent ground gained is vanishingly small between the $300 and the $3,000 protocol. I mean, I'm glad they did Parvo because I think it's a really important one, but I'm curious to just consider, like, wow. Right. I don't think that we've subjected everything we do in veterinary medicine to this kind of rigorous
but maybe we should.
I might have missed this, but did they control for the severity of disease between the 2 groups? Like how far along?
They had a rescue protocol.
I know because I know they didn't assign, right?
Nope, it was random.
Okay.
But then if a dog got to a certain point and was not responding, it got switched to the other group. But that only happened for one of the dogs.
Okay.
Did that answer your question? Yeah,
but when they started, they didn't control them. I mean, they didn't assign groups.
Nope, they were randomly assigned into the 2 groups. And they did also have another rescue. So before they moved the dog, they also had another rescue protocol that was buprenorphine and ondansetron. And then if those 2 treatments didn't help, then they would move the dog to the other group. And that only had to happen for 1 dog. Okay. So they did have those things. So they are very excited, and you can read about it on their website. The clinicians are happy to talk to people, but again, it has not been published. But just some discussion points for how this can help. How shelters can use this information. So I just wanted to see what people thought. I thought that this was a great study to support because a lot of shelters want to treat, but obviously, we're not sending the dogs home to be in one home where they aren't subjecting other animals potentially to disease. So, but I feel like if a shelter has appropriate isolation or they can work with a clinic, that seeing that there are other ways to do it is really, really encouraging for us. Any thoughts on that? But in respect to thinking about that, remember that this study was done by VMTH staff, and they had 24-hour surveillance. So not all shelters are going to have that.
Did they actually check, did they keep an eye on the treatment dogs 24 hours? So they checked on them throughout the evening?
Yeah. Because in a home, the person would potentially be there. Not necessarily 24 hours, but, I think that was their thought. So they were monitored.
True.
Yeah. But I still think it's really exciting.
But just have some thoughts or cautions on what, if we were going to post this on our Facebook page this afternoon to say, hey, did you all see this great treatment for Parvo? Try this at home. Or if we were going to link to this on our website in our Parvo section, what would be some guidelines that we would want to put in place of what constitutes appropriate isolation? And also what constitutes sort of minimal appropriate monitoring? At what point do you say, you
need to go to the hospital?
Well, either you need to go to the hospital, or if you can't provide this level of monitoring, it's not fair, and you should just euthanize the puppies instead. At what point do we say that? Because I think we tend to really think about, you have to have all the stuff in place, and we don't want puppies to suffer. But sometimes I think we actually hold shelters to a higher standard than we hold owners. We should, as far as isolation goes. But if we can provide adequate isolation, what is sort of like, what would you say, like, as long as you have monitoring and the ability to do TID treatments with the puppy unattended for no more than 8 hours? Or do you think we even need to make that kind of recommendation, or just urge people to consider? You know, you don't want to think about some puppy that gets this last meds at 4 in the afternoon and then it's locked in the shelter's bathroom until 9 the next morning. And it, you know, bled out and died at that time.
Like, I personally think it depends somewhat on the clinical picture of that dog. If it's, you know, somewhat stable, not super dehydrated, not actively vomiting, not having horrible blowout diarrhea, and you think you can leave it so it's not going to become super dehydrated overnight, then I'd be more likely to do something like this as opposed to IV fluids.
Because that's kind of tricky, because what if they do have some blowouts overnight, right?
Yeah.
And then they're going to be really behind.
Right, but if they're already doing that, then I wouldn't consider that for one like this. If it was fairly stable, could eat a little bit, then I would potentially consider doing outpatient.
Because, Cindy, whoever relayed this briefly at the ACVIM conference mentioned that if initial
It was
fluid...
at ACVIM.
We just barely... Do you remember someone briefly talked about it, either Dr. Hurley or Dr. Griffin at ABBC?
Dr. Griffin.
Okay. So she mentioned that if initial fluid hydration was needed, that they did do that, if some resuscitation was needed in that case.
Yeah, and they did here. That's how they started.
Okay.
So they caught up on their losses.
Okay.
And then they put them in,
So
which I think would be...
Do you know over how long time they got their initial IV treatment? It'd be somewhat limiting to it. Yeah.
And I don't know if some required longer, if they then weren't able to go into the study. That I don't know. Didn't mention that.
Cindy, this is Kathy Makalinski. I'm having a little bit of trouble hearing, so I don't know if you already addressed this, but at least from parvo cases that I've seen, they can run the gamut of clinical signs. So I'm just wondering if, like, there was any effort to randomize based on clinical signs, like were some really severe dogs put in one group and
It was completely
not
random.
in the other?
So as far as I know, as it's been presented, it was completely random. They did, all dogs on presentation got IV fluids with dextrose and heat support, and I don't know if some dogs required too much that they weren't able to go into the study. That I don't know, but the two groups were completely random.
Okay. And like even based on CBC, if the white blood cell count was really low, I'm wondering if they got put into the outpatient treatment.
Only one dog had to be moved. So they monitored it in both groups, and between the two groups there were no significant difference between the two treatments. But one dog did deteriorate clinically, and that dog had to be moved to the inpatient group. So that dog went on to the more intensive treatment.
Thank you.
One thing that would be interesting to ask the authors might be, everyone volunteered for this study. Were there some criteria by which they were offered participation in this study? Like, you know, if the dog was too severe on presentation.
Right, they may not have been offered.
Did they not offer it, or was it just anyone who couldn't afford it? And in that case, you know, we would think there was a wider range of clinical presentations to start with. And that would be good information for shelters to have, if there really was, you know, and maybe this data will be available when it's published, what the average starting clinical score was.
Right, so then a shelter...
So that we can kind of say, you know,
right.
Well, at least with a clinical score of this, there was no significant difference in outcome. If the clinical score is worse,
may not be the case.
Then this may not be the optimal garden path to trot down.
You know, I agree with Kate. We have so little information about the design of this study that it's really hard to assess the quality of it. I mean, it may be a wonderful study, but with what we know, we don't really know what the inclusion or exclusion criteria were. We don't know the method of randomization. One of my colleagues was the editor for Preventive Veterinary Medicine, and she found that when she started asking people to describe what randomization was, they in fact often were doing haphazard allocation to treatment. And when they didn't understand the difference between randomization and haphazard or something that was not random. The other interesting thing is that they called this a case control study. That's a very bizarre label for this, in that they were randomized. This is obviously a clinical trial done in a clinical situation. So it makes me worry a little bit about.
That's my bad. I called it a case control. My bad. It's a prospective clinical study. That they didn't. I did.
Oh, okay. Then rest assured, it's not a case control study. Case control studies are observational, and this is and you want to call this a randomized trial. A randomized trial is definitely the source of much better information than a case control study would be.
Dr. Scarlett,
but
could I
it'd be lovely to see a lot more details on this.
Dr. Scarlett, could I interest you in refreshing the group's memory on the difference between randomization and haphazardness?
Sure. So you need and lots of people use the word randomization because they've learned that that's like the buzzword to use. And so what we like to see is some description of the randomization. It could be a random number table in which they say all odd numbers that come up between 1 and 20 or 1 and 40 here go into the treatment A, and the even numbers go into treatment B unless one group fills up, and then the rest of them go into the other treatment. It could be a random number generator, but it needs to be something that has a true random element to it. It could even be something where you mixed a bunch of numbers in a hat and drew out the first 10 go into one treatment group and the latter 10 go into another, so long as you can shake them up and there isn't some kind of weird description. But today, with all the computerization, it's lovely to get on and just get a random number generator.
Dr. Scarlett, this is Cinda Crawford. You'll read a lot of randomized clinical trials that state the animals or people were randomized by, like, every other animal was placed in a different group.
Right.
As they were enrolled. Do you?
It's really not random. It's a
systematic. That's the haphazard. That's the haphazard, isn't it?
Well, no, it's a systematic allocation.
Okay.
Which is different than haphazard. I mean, often they have a random start and then a systematic, so the next animal gets A, then the one after that gets B, and the one after that gets C, and the other, A and then B. That's a systematic with a random start. The question under those circumstances, is it easy for somebody to recognize the pattern? And if they can recognize the pattern, then your likelihood of eliminating bias, or at least minimizing bias, goes up, or goes down. The likelihood of minimizing it goes down. So it's still not haphazard. It's a systematic with a random start, but people don't like it. It's not the preferred method because it means that potentially the person who's observing the outcome can figure out what the system was and therefore predict which animals are in which group.
Dr. Scarlett, would there be any point in a study like this where it was obvious to the people who are doing the clinical scoring which group the puppies were in because they were in a different ward? Is there any advantage of randomization over systematic allocation in that setting?
I think you always want to go for randomization because the very fact that you allow somebody to actually determine, you got to worry that the severity of the illness or something about the presentation causes them to put an animal in one group or another. So you always want randomization. Then you want masking or blinding if you can get it, but you can't always get it. And if you don't have blinding or masking, then you want to try to make your outcome measure as objective as possible. Because once it becomes subjective and you know which group an animal is in, then you're in more trouble. Then you've got the opportunity for bias to creep in. It's all of these studies are all about bias. How can we minimize bias? Probably never completely eliminate it, but how do we minimize it?
Yeah, and these animals were getting different treatments, so.
In different places.
I mean, I'm not saying this is a bad study. I'm just simply saying that there are so few details that it's hard to know how good the study is.
Yes, and like I said,
it'd be lovely to see the publication and go back over the study. It would be lovely to see the publication and go back over the study, and then Kathy's questions about, who was included, were there exclusion or inclusion criteria, what was the method of the randomization, all of that would be much clearer then.
But exciting nonetheless so then I wanted to make you guys all aware of a new book that's out. Dr. Jane Sykes came out with the Canine and Feline Infectious Diseases, and you guys all got to see her chapter. And this is just a little bit, I looked at the treatment recommendations from her and from Green's and from our own Dr. Hurley's infectious disease book. Just so, as the shelter's making up their outpatient protocol, that they hit on all the important parts, and they're all very much in agreement of the most critical points are fluid therapy, and then electrolyte balances, and making sure maintenance of blood glucose, a good nutritional plane. So this is a nice table from Dr. Sykes' book. Dr. Green, Green's Infectious Diseases of the Dog and Cat, again, restore fluid losses and electrolyte balances, and be sure to prevent secondary infections. He also has a really nice table that is in the book. I do not have a digital copy, so thus not sharing it here. And then, again, in the infectious disease management in animal shelters. Of course, we have to talk about balancing risk, the population, prognosis, and cost. Even at this lower cost, is it even realistic for some shelters? And I just wanted to make sure everyone has another paper we could talk about at some point, but that everyone's read this one about the importance of feeding these guys early. Even it was thought for a long time that it was traditionally thought that waiting until 12 hours after clinical signs had ceased, so after the vomiting was done, that's when dogs should be fed. But they showed this study that starting treatment by an NG tube from the first day of treatment really did shorten the recovery time and help the animals maintain their body weight. So regardless of the type of treatment that the dogs get, that early feeding really, really, really is important to these guys in their recovery.
So when you say really, really, how much better did the dogs do that got fed?
I would have to go back and review the paper.
Because I think it's like a day. So, yes, a day in ICU is expensive, but I would be cautious about overemphasizing the impact that had. And my other question is about antibiotics. I'm curious what other people think about using Baytril at those doses and the risk of cartilage injury.
I don't think there's a big risk.
Here at Oregon Humane Society, we do use Baytril no matter the breed, because we feel like the risk of dying from parvo is greater than potential cartilage problems down the road. That's just what we do. We think it's treat the fatal disease and risk a possible hiccup down the road.
And does anybody recall the literature on the cartilage dosing? What kind of animals are the cartilage damaged? What kind of animals are susceptible to this, and what doses were used?
Yes.
Well, I know you do, but I'm asking them.
I don't know the details of the study. I know from my memory it was more microscopic changes, and there wasn't a lot of evidence of clinical changes, but it's been a while since I looked into it.
And it's usually much higher doses. If the slide has gone by, but I think it said 5 milligrams once a day, which isn't even. Can you go back to that previous slide? I don't even think that's the right dose for a dog. Is
don't dogs, aren't they supposed to get BID treatment?
I thought it was BID, yeah.
Well, yeah, we give it 5 mg per kg BID at Oregon Humane.
Yeah, so I'm wondering, like, where it's not referenced. It says Chapter 8, so it'll be interesting what's in Chapter 8. But this seems like an abundance of caution to remove on this list what is the most potent antibiotic against gram-negative bacteria, which is what these dogs die of usually if they're going to get septic. In the old days before Baytril, we used lots of amikacin because we felt like we had to fill in that gap in puppies, and that seemed to work fine too. But I'm just, unless you're treating like giant breed, rapidly growing dogs with higher doses of Baytril than this, I would not expect to see a problem.
And we asked Dr. Mark Papich at NC State, boarded veterinary pharmacologist, about use of Baytril or any of the fluoroquinolones in puppies, and basically in his mind it's low risk for cartilage damage, especially if you're using it in puppies that are so severely ill that they're immobile, because the studies actually worked with healthy fast-growing puppies who were very mobile, putting a lot of weight on all their joints, jumping around, running and playing like normal puppies, whereas your severely ill puppy that's just basically a little lump is not putting the same stressors on the joints in the face of fluoroquinolone antibiotic treatment.
And then one last pickiness about this drug table. Can any of the house officers on the call comment on that famotidine dosing regimen? Is that appropriate? No. I hear someone say no. Yeah, famotidine has been shown in dogs to have a shorter duration of activity than it does in people, so it has to be given twice a day to have continuous effect.
So, points to be made against the treatment recommendations.
The ex-Davis students are all remembering that here at the VMTH we do 5 mg per kg once a day of enrofloxacin. It's the standard dose that all the internal medicine clinicians used when we were in clinic.
In dogs?
Yep.
Yeah, and I've seen that too. I do agree, but I think at least the old recommended dosing frequency was 2.5 mg per kilogram twice daily. I think it morphed into a total of 5 milligrams once daily for...
The original was, it doesn't matter, the original was 5, and then it was way up in cats, and that's when they saw the retinal toxicity, so it's back down in cats. But anyway, so someone should dig up
I remember there was something about it being concentration dependent instead of time dependent, and then, but I also seem to remember then they went back on that.
Yeah, I think the more...
Apparently David still thinks it's concentration dependent.
Yeah. So that's why they go with
but
it.
I know in emergency medicine we switched to preferable SID dosing on Baytril about 6 years ago, and we do still do that. We go 5 mg per kg once a day, or if we think they're really, really septic, up to 10 mg per kg in a dog. The other thing I see missing on the drug chart is there's no Unison on there, and Unison is one of the new favorite broad-spectrum antibiotics that we use a lot in parvo puppies and emergency clinics.
And that's once a day, right?
No, Unison is 3 times a day, IV, PID.
What group of antibiotics is that? The super awesome kind of potentiated penicillin.
It's amoxicillin sulfobactam.
So it's like injectable Clavamox.
It's like injectable Clavamox, but I think it has a little bit broader spectrum than Clavamox does, but yeah, it's definitely injectable.
And I just looked up the dose for Baytril in dogs. It's 5 mg per kilogram once daily.
Is that from Plums?
That online, yes.
Oh, okay.
Well,
It says preferably once daily, and it's starting dose of 5 mg per kilogram, but it has ranged up to 20 milligrams per kilogram.
Yeah, I think Plum says 5 to 20 once daily or divided.
Yeah.
Kate, if you're still out there, what drug and dose do you prefer at the San Francisco SPCA?
We use, we send all of our Parvo animals over to the hospital, and right now I'm working on a Parvo. They have a new Parvo bag, and they use the ACVIM in the bag, so it's an IV treatment. As we use the phenylphosphocin, we tend to use the 5 mg per kg once a day in the shelter. Generally.
Did everyone catch I didn't catch what was in the bag.
Oh, in the Parvo bag, the SPCA?
Yeah.
We went from some very aggressive Parvo treatment for Parvo patients at an average cost to a client of about $3,500, anywhere from $500 to about $4,000 a patient. And most of the patients that were Parvo puppies were actually financial assistance clients through the hospital. So the hospital was challenged with trying to come up with a cheaper protocol to treat these patients. So what they came up with is this thing called a Parvo bag that basically is
cutting out.
Percentage of 50% dextrose. They have a very set protocol on how to treat these Parvo puppies now, and the cost has dropped to about $1,500. So what it's doing is allow us to take in more financial assistance patients, and we've been doing that probably for about 8 months, and I'd say it's about the same survivability. Probably about 95% would survive.
Kate, tragically, you cut out just when you were describing what the Parvo bag involves. Is it possible you could share that protocol with the group, or is that something you'd rather?
Yeah.
Okay.
No, absolutely. I'll even. How should I do that? Email it to yourself or Cindy?
Email to Mike if you have his email, and otherwise Cindy or I can pass it along.
The Parvo bag, and then the natural bag, and what we do when we what other modalities. Earlier on, some of these guys for the reason that it does decreases the time in the hospital. So we have started doing that with some of these guys. But yeah, happy to share that.
Awesome. Thank you.
I thought she said that's the dog. Oh, that could be. What else? Anyone else?
Anyway.
Fun times that we get to talk so much about treatment in shelter medicine. Why, in my day, this was not even on the radar.
No treating?
No treating. We were so worried about preventing that we never got around to talking about treatment. You kids don't even know how it was when I was young.
So when, this was a while back now, Dr. Hurley and I, when we were working with San Francisco SPCA, we thought this was really kind of fun. Because, again, they were talking about, Dr. Kuzminski is going to talk about this more, but we worked with them on a program to help bring in more puppies to their shelter. And they told us that originally, like she said, that they were sending all their Parvo cases over to the hospital, and it was costing them upwards of $3,500 to $4,000 for each puppy. I'm like, wow, that seems really pricey. And so, what if and so I talked to a bunch of different shelter vets and got different treatments and kind of different costs. And so we put it into this calculator, which is really quite fun to play with, and we're happy to share it with you all because it's actually in this fun Excel spreadsheet, and you can play around with it. So you can see, so if you want to switch it, and let's say in your particular shelter it still costs about $300 to treat your puppies. But the survival rate you're actually finding with your treatment is actually quite nice. You're saving 80% of your puppies. And what was really interesting in this was San Francisco SPCA was transferring most of their puppies. And so if of the transfers that were coming in, 20% got sick, but then we knew that if they weren't saved, they weren't transferred, they had a pretty high risk. And let's just be really morbid today, and let's say that it actually became a 75% chance that they weren't going to make it. You could see that the average cost per life saved was $375. But look how many puppies they were able to save overall. Close to 1,900, whereas if they had to stick with their $3,500, and they were still...
Let's say they saved 90%.
Yeah. We'll make this one the same. Sadly, that's how many puppies they'd be able to help. So, it's just kind of fun to play around with, to see how, obviously, we're not saving them all, but it helps to be a predictor of the lives that can be saved on different budgets, our Parvo budgets. So we can share this with people too if they want to play around with the Parvo treatment cost calculator. Really big at holiday parties. Here.
You should send it to Aaron Rodgers.
I'm sure Aaron Rodgers would love that as a birthday gift.
And just for you, in case this isn't clear, this is just imagining a scenario where the shelter does have a fixed budget.
Yeah.
They got $100,000 to treat Parvo, so, obviously that's going to be a smaller budget. But that's one of the differences in shelter medicine where, the composite budget of all the clients is not necessarily fixed. So you don't have necessarily the same parameters for how many lives you get to save. This would play out if all the clients sort of put their money into a pool, like puppy health insurance pool, and then we treated as many as we could in that pool. It would work that way, but this is more appropriate for the shelter scenario where, like, you have a $10,000 angel grant or something to treat Parvo, and it feels like it would be best to give them the best possible treatment, but you can actually save a whole lot more by giving a cheaper, slightly less effective treatment.
It would be kind of interesting to make it go backwards, too. I guess it does kind of with the cost. Not exactly. It would be kind of interesting to make it go backwards and sort of say, like, well, if you want to save this much, and then, like, here's what budget you would need.
True. An Excel wizard who's better than us might need to put that together.
Well, I think you'd have to make another one, but it's awesome. But it would be cool, because for people because it seems like a lot of shelters don't necessarily start with like a fixed budget. They start with, a lot of shelters do. So this is amazing. This is really cool. But it would be kind of cool to turn it and make it go the other direction too, like to do it like, we'd like to be able to transport, 1,500 and show them.
What budget you should anticipate having.
Right, if you're going to do it, depending on what scenario you're going to do. But this is awesome. It's incredibly powerful to show, like, when you change the scenario, how many more lives you can save. Mm-hmm. It's really cool.
Are they enough? So, yeah, it's fun. Share that with all your friends and neighbors. So then getting back to our project with the San Francisco SPCA, which we named No Puppy Left Behind. Because the whole goal was actually they didn't have enough puppies, believe it or not. So they wanted to transfer in more. And so originally the thought was that, they wanted to take healthy puppies, but so Dr. Hurley talked to them about using Titers, and originally it was thought that maybe you would just take the Titer positive ones because that felt less risky. But then who could walk into a shelter and leave puppies behind? That just seemed too traumatic. to have those faces looking at you, and because they were negative, they had to be left behind. So we came up with a plan to allow puppies to be moved safely. So what we suggested, Dr. Kuzminski is going to go into what actually happened, but this is what our recommendation was. That
always fascinating to see the difference.
We thought it would be kind of fun. We decided that was the route we were going to go. So.
Oh, is that what you recommended?
Yeah. Just waiting to say that. Like, oh. So, and originally, the titers are now done. Hey, correct me if I'm wrong, but they're done at the shelter, right? So.
Yeah.
If healthy at the transfer shelter, they get transferred to San Francisco and are then tested at the shelter. So they don't have to leave puppies behind. They don't have to leave healthy puppies behind, which is fantastic. So the idea was if they test positive, so this is if they actually do want a positive test, they were bathed, they waited 48 hours, and they went into surgery and straight up to adoption. They would continue with their current vaccination schedule that they were using and their the protocol that the San Francisco SPCA already had for handling the puppies on the adoption floor.
They were really into the bathing thing.
Yeah.
So that was the plan for titer positive. Titer negative still got to come, and then these guys would be quarantined. And this is where we left it up to the San Francisco SPCA to decide how long they wanted to quarantine. In Dr. Hurley's experience, she said that 7 days really will pick up most of them, especially if they've gotten if they're from a high-risk shelter and it was a pretty large dose that they got. But obviously we know Parvo has an incubation time of 14 days, so you are accepting some risk with that quarantine. So you can make it longer, and then with the thought that a longer quarantine does mean more time in the shelter, but that you would pick up all of the puppies at that point.
And residents, I want you to take note of the cleverly hedging and almost useless language that I use, going from a large percentage to the vast majority to almost all. That is code for I don't really know.
But this sounds good.
True.
So now Dr. Kuzminski is going to let us know how it actually happened.
And
okay, great.
I hope we can hear you. We were really breaking up badly before.
Okay, can you hear me now?
Yes.
Okay, so I am in a place where the cell service is poor, and just as you were talking, the Wi-Fi kicked out. So I don't have the slides in front of me, but I think I can probably, if you tell me what slides are up, I can go through them from memory and what I can pull up on my computer. Okay?
Yeah. Okay. Well, I'm going
great.
now to your first slide of puppy intake by year.
Okay, great. So historically, this has been our puppy intake. Where we get our puppies from, we transfer in almost all of them. We do take puppies from the San Francisco Animal Care and Control, and we would transfer some healthy puppies from areas such as Merced, but we would prearrange to bring in these puppies from sort of instant fosters or from other foster type situations. We were not actively taking puppies from our high risk shelters that we transfer in from. In 2012, why that? We started this puppy transfer program, Leave No Puppy Behind, in October of 2012. So between October and December of 2012, we during our pilot project for the Leave No Puppy Behind program, we transferred in 164 puppies in those 3 months. So that's why 2012 went up to 508. And the 2013 data is probably up until about a month ago, 3 weeks ago. So we'll probably hit about 520 puppies this year. Can you still hear me?
Yes, loud and clear. Okay, I'm going to the next slide, Kate.
Yep, thank you. So prior to October of last year, we would transfer our puppies in. We would quarantine them for 14 days. Pretty conservative, not very risky. Our adoption for Maddie's is group housing, and so if we ended up putting puppies into Maddie's and they broke with Parvo, that would be a bit of a disaster for us.
we have a newer building, but we were housing our puppies in the old building, which was much harder to clean, cracks in the floor, rusty corners, hinges, and not all the runs in the old building had dedicated drains. So we were actually housing our puppies, our most sensitive beings, in the most riskiest place within our facility. We have a great kitten foster program, but we have not had a good, prior to this, we did not have a good puppy foster program. It's much harder to find a significant number of puppy foster families than it is with kittens. By 2 weeks, families are done with puppies and they need a 2-week break. And so that we didn't have that established yet. And we did have a lot of volunteers who wanted to visit puppies, but we didn't have great visiting protocols for them. And like I said before, any puppy that broke with parvo, our culture is we would treat them. We would send them to the hospital. And again, average cost for puppy, the basic quote for parvo at that time was $3,500.
Next.
Okay.
Hi, Lydia.
So,
sorry, tell me.
In October of 2012, when Cindy and Kate came over and were helping us with our housing, I remember sitting at the table, and Kate, you said,
"Okay, sorry, I'll call back.
I wonder if you could use Titers for this," and that's just kind of where it began. So, even though we say no puppy left behind, that is kind of a misnomer. We do leave puppies behind in some of the shelters we transfer, but we're not selecting them based on their titer. We're going to take them all, and we're going to take on the risk of having them in-house. And they get bathed right from the time that they arrive. There's a group of volunteers that meets them at the door from the transfer vehicle. They're gowned up. They take them right to a bathtub before they actually even enter in the shelter, and they bathe them. And then they go into a room. I've just given you the room numbers just so as a reference. They go into room 2412, which is got 6 runs in there. It's not double-sided, and that's our puppy intake room. We use the VaxiCheck Titer program or test, and our techs do the Titer test within 24 hours of them coming into the shelter. Most of the puppies that when we transfer in, they don't arrive until the end of the day, and so to start this Titer test at the end of the day is our techs would never get out of there in decent time if we started it at when they arrive. So they have 24 hours to do the Titer test. Parvo Titer negative puppies go into a room called 2418, and they're in there for a 10-day quarantine. And then the Parvo Titer positive puppies go into 2416, and they're there for 48 hours. During our pilot project for this program from October to December, we had a 14-day quarantine for that, and after the 3 months, we assessed when did the puppies break with parvo, and when on what day, and we reduced based on that. They were all breaking within 5 days of coming into the shelter, every one of them. So we reduced the quarantine to 10 days for them, knowing that there's a slight risk that we won't catch them all, but based on what we saw during that pilot, and actually what we've seen since then, the 10 days I feel very comfortable with. 7 days I don't feel so comfortable yet with, but we'll see what happens in the future. The Titer positive puppies that are in 2416, they're there for a 48-hour quarantine. It's more just to see if they're going to break with kennel cough or break with something else. It also gives us time to get our intake or health check exams done. What we've also done since starting this program is we've increased our recruitment of puppy foster families, and we do have a much more active in-shelter puppy volunteer team that is specifically trained on quarantine procedures and working with puppies. So when they work with these guys, they're gowned up and they're gloved.
Awesome. Next slide.
Okay.
Population overview.
Yeah.
Can I just ask a question?
Yes.
When you're testing them, so you can get a positive on the Titer test with either exposure or with protective immunity. Are you also parvo testing them at the same time?
If we have, yeah, you're right. I mean, they could have a positive titer from either one, but I guess the premise, the theory that we're working with is that it's unlikely that if they have a protective, if they're clinical, we will absolutely test them at the same time. But if they're not clinical, we are working on the assumption that they either have their mom's antibodies or they were exposed prior. I don't know how long it takes to get a really, really strong high titer result, a strong titer result on these tests. But if they're very strong positive, we are working on the assumption that they are protected versus they are sick or clinical for it. We have had animals who, I don't think we've had any, well, we'll go through it, but we've only had two animals that were titer positive that broke with parvo later.
This is Sandra. One of the things that that we started basing that whole process of sort of using titer evaluations in healthy dogs was based on research that Schultz had done on dogs that had been challenged and then became ill. And what he told us is that a dog who was not currently showing any clinical signs and had a strong positive titer was very, very unlikely to become ill. And so that's sort of like looking at his data. That's how we started doing this many years ago, and we have had really good success with that. In puppies, it can be a little trickier because, and we were always a lot more cautious with puppies because we felt like, oh, well, you don't know. It could be just maternal antibodies. And I think Kate saw in one case that she handled, but the dogs were all the same breed. She saw puppies who were antibody positive and had no clinical signs who then did go on to become sick. But I have not seen that very commonly, if at all, in the work that we do on outbreaks in shelters.
Yeah. Our experience so far is has not been that they're ill or they're clinically ill at all, or that they're actually Parvovirus positive versus just titer positive. And the next slide kind of just breaks down what we have found as far as the scoring of the parvo titers in the puppies that we brought in. So these numbers are every puppy we brought in from October 2012 up until now. These are not dogs that we knew were parvo positive when we brought in, which we do bring in a lot of known parvo positive puppies from animal care and control. These are the ones that were clinically well when we brought them in. And so a score of 3 or higher is titer positive for us. If there's any question at all when a technician is looking at the color, we'll err on the side of caution, and we'll call it a 2, and we'll call them parvo titer negative, which is why I think we have the spike in the 2s in here. But that's for us that's so I can sleep at night. And I'd rather err on the side of caution and hold up maybe some positive puppies versus moving some potentially negative ones that were going to break with parvo to our system. And what we found was half were parvo positive or titer positive, and half were titer negative. When we did our pilot project last year, when we had a much smaller number, when we had about 164 and not over 500, you could see, you thought there was a pattern based on the source, the transfer partner. Like I could look at the numbers and say 80% of the puppies coming from Stockton are titer positive, and I got kind of excited about that. Or like none of the puppies coming from Merced are titer positive. And so at that time I was thinking we could actually use that information to bring in more animals. But as our N has gotten larger, that it's averaged out. Okay. So this is just some Titer data by our transfer partner. We get over 90% of our puppies are from 3 sources. One is Merced shelter. The other one is San Francisco, and Stockton is our third one. Prior to last October, we weren't taking any puppies from Stockton because they were all breaking with parvo, and their adult dogs were when we brought them in. But we've fixed that out there now. I think that within the agencies now we know that half of them coming in are going to be pretty much Titer positive, and half are going to be Titer negative. So it hasn't panned out as far as sourcing as much as I thought it might initially. What I found interesting and was just sort of curious with our results was how many of the parvo Titer positive animals were also distemper Titer positive. Because in our initial pilot project, we were getting, say, 80% of the animals from Stockton, puppies from Stockton, were parvo Titer positive, but like 10% were also distemper Titer positive, which then, and then the animals coming from Merced, a very small number of them were actually parvo Titer positive, which Merced is such a geographically large area. Puppies were not coming into the shelter. My assumption was that they were staying in they were on someone's property. They were not exposed to parvo. They were not vaccinated, so their titers were going to be negative. Whereas the guys that came from Stockton, lots of parvo there, their titers were positive for parvo, but they were significantly, most of them were negative for distemper, which told me that there's not a very good vaccine program in Stockton. But when we look at San Francisco on this slide, we have a significant amount of the number of the dogs that are testing parvo Titer positive that are also distemper Titer positive, which is kind of, to me, and we don't have a lot of distemper in San Francisco, so that tells me that a lot of these dogs probably have been vaccinated, or they have maternal antibodies. But then we did have that one, so for the next slide, we did have, out of this group of puppies, we had 29 confirmed parvo cases that came in, and 27 of them were negative on intake, but 2 of them were positive for titers. And Tiffany and Stephanie, they were from Merced, and they broke with parvo 6 days after intake. And they came in with a group of puppies who were negative titers, and 2 other puppies in that group broke with parvo 3 weeks after intake. So that tells me they got it at our place. Bobby and Peter did. And I think at the beginning, when we were thinking about what rooms were going to be the high-risk rooms and what rooms were we really, really strict on as far as cleaning protocols and handling protocols, and we were focusing on 2418, which we knew was the Titer negative room. And while we knew 2412 was a high-risk room as well, I don't think that we were treating it as conscientiously as we were 2418, and I'm not sure why. And this was right at the beginning when we were trying to work out our bugs. And so what I think happened is that some of these puppies were actually housed in the same run in 2412 where there had been parvo prior to them going in there. Now, the unfortunate thing about Tiffany and Stephanie is that they came in and they had their 48 hours in 2416, and then they went to Maddie's adoption floor on the first day of a 3-day adopt-a-thon. And so they went into a room, and 2 hours after our adopt-a-thon started on a Friday night, and there's like hundreds of people there, they broke with parvo in Maddie's. So it was not ideal, but it was fine. So when we started this, the other aspect of us starting this Leave No Puppy Behind program is that we had to do a bit of a shift in our head as far as determining of whether are we going to treat every puppy that comes in now with parvo, because we only have limited funds, and we're now going to increase the number of puppies that we are bringing in, and can we really afford to $3,500 a puppy? And so that was a bit of a cultural change and a bit of a change for me to come to terms with making a decision on that. But what I had learned from prior puppies going over to the hospital is that the guys that carry the worst prognosis are those very tiny, rare brown chihuahuas that are like 0.4 kilograms. And so through this whole period of time, I only chose to euthanize two of the puppies and not send them to the hospital because I didn't feel that they were going to have a very good prognosis. At the same time, the hospital was challenged with trying to come up with a more affordable parvo treatment, and they came up with the parvo bag. So it worked out really well. They were able to reduce their cost down to, or their cost to a client down to $1,500 a case, and we were able to send more puppies over and still stay within a reasonable budget.
Okay.
And then the yes.
Can we go back to the interpretation of the canine vaccine check scores for protective antibody titers?
Sure.
This one?
No, the one with Bobby and Stephanie and Peter and Paul and Mary.
Yeah.
There we go.
Tiffany and Stephanie, 3 and 4. Yeah.
So the canine vaccine check has a low specificity, relatively speaking, for both Distomper and Parve, meaning that you get a lot of false positives. False positives means the titer was falsely predicted to be protective. The specificity that we did a study on 400 samples, serum samples from dogs, and all these serum samples had true gold standard antibody titers determined at Cornell by the hemagglutination inhibition assay, and these same samples were tested in a blinded fashion with canine vaccine check. And we found that when you go by the manufacturer's recommendations that your cutoff score for protective antibody titer is 3, then you will have false positives. And when we looked at the false positives in our research project, they had Cornell determined antibody titers right around the cutoff by the gold standard assay, if that makes any sense. Serum samples.
I agree with what Cinda's finding, that sometimes that 3 is a little bit of a gray zone.
Yeah. So
I had a question about Tiffany and Stephanie too, which is, were they free of clinical signs? I was a little bit confused about that. Are you titer testing dogs that are healthy and free of clinical signs and sick dogs, or only the dogs who are healthy and free of any clinical signs?
So we won't transfer any puppies in if they're having diarrhea, and our intake crew is out at one of the shelters. So they have to be clinically well for us to bring the puppies in as the initial step. Once they get into into the shelter, we are only parvo testing animals who develop diarrhea while they're with us. We are titer testing, and so we don't have clinically sick ones that we are aware of initially.
Okay, so everybody
titer testing all.
Everybody you're titer testing is free of clinical signs.
Yep, we are titer testing everybody, but we're only parvo snap testing those ones who have diarrhea.
So I would suggest, for your consideration as you move forward with this great project, that you consider a protective antibody titer to have a score greater than 3.
Okay.
So that you don't have false positives, and mainly so that if you're going to call anything with a score of 3 or less as negative for protective immunity, then you know to handle them with kid gloves.
Yeah.
But if they have a score of 4 or higher, they are more predictive of having true protective immunity. May not need to have. They can move through that fast track program of surgery within 48 hours and placed on the adoption floor.
I think I mean, I want to see the rest of your slides first, but I think that all respect to Cinda and what she's saying, but I think you would have to really think about the risk of holding back the 3s versus the risk of sending the 3s through. Do you know what I mean? Like somehow you'd have to balance those, because I really see them in that gray area, and I could see you making a decision either way, but maybe realizing that every now and then, you know, there may be.
I agree with that philosophy. It's better to get them into a safe environment very quickly, such as a home, as opposed to holding them back.
Right, like knowing, you know what I mean, like knowing every now and then you got it wrong, which you did with these 2, but like how many moved on where that was really the right choice to make.
Yeah, no, I agree with that.
Yeah, thanks.
I mean, my greatest fear would be to adopt an animal out and have it break with parvo in the home after getting there. As far as that would.
But the thing is about that is like that is everybody's greatest fear in some ways, but in other ways, like you can never really prevent that. I mean, unless you never want to adopt out any puppies. So every now and then, that might happen.
Mm-hmm.
But I think you have to kind of look at balancing the risk, knowing it's never going to be perfect, because holding puppies in the shelter longer could actually potentially mean that you would adopt more with parvo, like you saw in Bobby and Peter, right?
Yeah, absolutely.
So that's the whole trick in balancing these things, is that the shelter isn't necessarily safe, so holding them in the shelter longer doesn't necessarily get you to your perfect goal of never adopt a dog out with parvo. And so instead, maybe a better goal is rarely adopt a puppy with parvo.
Yeah, and to my knowledge, we haven't yet. And this program has been a way to, I feel very comfortable with what we've done here, and we have taken on far more risk than what we traditionally have done. And so I know that we have gotten almost 300 or over 200 animals out really quick, which has been great. And they haven't gotten sick from anything else, and they got socialized. And the Tiffany Stephanie was a learning experience. So, but anyways, that is good information, though. Pardon?
I was going to say, the nice thing is you could track this. You could actually calculate your false positive rate.
Yeah. The other thing, and it might be cool if Julie and Cinda already did the antibody study they did, if you save your serum, I don't know, whether Cornell or Schultz might be interested too. If you want to send it in for gold standard, you could see over time in your hands with those VaxiCheck where those are coming out with the gold standard comparatively.
Yeah, you could do it that way, but you also know how many test positive, right? You know how many test positive, and just keep track of how many broke with parvo among those at each titer or at each cutoff, and that way you could actually determine, from in a very practical sense, what your false positive rate was. It sounds like it's low.
Except, Dan, that would have to be, not only was it a false positive, but they also got exposed to parvo.
Yes, that was the risk. They weren't protected, and they were
exposure. Then you'd have other animals in the same room, right, that broke? Or are you saying that some of those are subclinically shedding? Is that what you're saying?
I'm saying that if you're only counting the ones that went on to develop parvo, those ones for sure they tested positive, but they were unprotected.
Right.
but you're probably missing others that tested positive that were unprotected, but they just never got exposed.
So they were unprotected, right? I mean,
but you won't know about them.
So they got.
But you wouldn't know about them if you were only counting the ones who got sick. That's what I'm talking about.
Right.
Well, I was just saying, their false positives are a total of your true positives and false positives, right? So, I mean, of those that test positive that are allegedly protected, what percentage of those went on to get disease? I mean, and it may be true that some of those positives never got exposed, but in your hands, in your shelter, over time, if that was fairly consistent, you'd have a pretty good estimate of what proportion of your positive test animals broke at 3 or higher, or 3 or lower, or 2 or higher. And you'd actually have empirical data to say, how well are we doing?
Yeah, and to say, like, how risky is that 3? If it's really, like, dogs, 2 puppies out of 1,800, that's probably a risk, hopefully, that you want to live with, versus if you held back all those 3s, how much more resources it would take, or how many fewer dogs you could transport in.
Yeah.
Go back.
I mean, you can actually look. In your experience, in your shelter, what do you get? Yeah. What's the difference between the, cut off at one place or the cut off at another?
Yeah, and it would,
kind of a
if we
experiment, with your shelter, in your hands, with the exposure potential that you have there.
If we went to this shelter high, I had the sense that it was actually quite low.
Is exposure at our shelter?
Yeah.
Yeah. I mean, at San Francisco, at our shelter, we don't have parvo unless we bring it in, and we brought in, 29 cases of it in these puppies in the last year. We don't have parvo in adults. We transfer animals in that have vaccines on board for at least 5 days. So we don't tend to bring, and we work with our transfer partners to establish vaccine protocols so that the animals that we are bringing in are not breaking with parvo. That's taken some time to get to, but we haven't had a case of adult parvo in the shelter for almost 2.5 years. So it's rare for us to bring it in.
I think your data that you're showing here of your 29 cases, that 27 had negative parvo titers, that's pretty profound. It seems like it's going to be hard for you to improve upon that predictive value. And then of the 2 that did break, that had positive, 1 had a 5, which is a really high score. So trying to adjust the cutoff point based on that, I think, would be really hard. It looks like you've hit it just right to me.
Yeah, I agree. I think that you're going to find that there's almost no difference at all between, cutoff in one place or the other. I don't, based on just the little data that you have here.
Right. And if we did switch to 4 as our cutoff, it would result in us bringing in far less puppies, just because they would be held up in 24/18, and we don't have a lot of extra room. So it would be interesting to really figure out how many less puppies that would be that aren't
that was
alive.
That I think in terms of kind of life-saving capacity, I think it's probably worth a little additional risk in terms of your cutoff. Yeah. The only other thing, what I was trying to say is the other thing that I've seen, and again, no critique intended, but I've definitely seen more with the Titer check kits than with the VaxiCheck, just because I haven't looked at it as carefully with the VaxiCheck. But I definitely saw variation from shelter to shelter in terms of how accurate the tests were, and I think a lot of it had to do with just really knowing how to run the test and all that stuff. So what I often used to offer to shelters that were getting started doing a program like this is I'd have them run their own, and then we'd run them in the Schultz lab, and we'd tell them, yeah, you got them all right, or, oh, my gosh, you guys are all over the map. And then they'd, tighten up their procedures for running the test and do it again, and we'd see them get better, more and more accurate compared to the gold standard.
It is a very, it's a test that takes time. We are fortunate that we have a number of technicians, and we have one technician that is dedicated to lab work a particular day. So she knows that when she starts this test, she can't leave the lab. She has to be there for the 2-minute dip, the 4-minute dip, and it's very it's taken the team a bit of time to work out the bugs initially, but I believe they are running it very accurately and paying very close attention to it. But it is a little complicated.
Just an observation and a plug for this study that's been proposed. Maybe some resident can undertake. That when we did the guide dogs outbreak, it was one of those times where there was very, very high exposure. So clinically, it played out that really all the titer negative puppies got parvo, period. And we had the Schultz lab run it, and then we ran the symbiotics titer check, and the clinical cases played out with the titer check and not with the Schultz lab results. So when there was disagreement between the titer check and the gold standard, it played out with the titer check. So when we had titer check positive, Schultz lab negative, those ones didn't get parvo, and vice versa.
Do you know, Kate, if they actually ran the gold standard in the Schultz lab, though, or did they run VaxiCheck or the titer check at the Schultz lab?
We got it back as titers.
Okay.
It was actually
numbers.
Titers, yes. It was numerical
numbers.
titers.
It was numerical numbers. Yeah, then they probably ran the HA.
Yeah, so it's interesting. So it would just be interesting to see not only how it agreed with the gold standard, but how that played out clinically. If you had some, positive by the gold standard, or, that it came out VaxiCheck positive, and gulp, it was gold standard negative, but they didn't get parvo.
That would be.
Finally.
Okay. So then, are you on our last slide?
I am.
Okay. So,
one more time, but it's a different question this time, Kate, so please excuse me. I never did get what was in the Parve treatment bag. Parve bag.
Yeah. Right. Okay. So I'm going to send that.
Okay.
I'm going to send our Parvo bag recipe and the protocol that we use to Mike, and Mike will send it on to everybody.
Great.
Okay. Yeah.
Very
happy
good.
to do that. So finally, what this has meant for us is that we were able to move 277 puppies to adoptions theoretically in 4 days. Like when we get busy, we get big intakes. Like what our gold standard would be is that 24 hours in that intake room and 48 hours for the positive titers in that 24/16, and then to spay, neuter, and on to Maddie. Sometimes we have a few days held up there, but still, 277 puppies moving out of our place in 4 days versus hanging on to them for 14 days like we used to do. It was a huge major cost savings for us, as well as real socialization benefits for those puppies to get into a home where they can actually live normally. What it also meant is that we can predict where the parvo, for the most part, is going to emerge. We know exactly the rooms, and that's held true during this whole program. We can target our volunteer resources more. Right now, what we have done is we are actually keeping volunteers out of that intake room, the 24/12 and the 24/16, because in theory, we want those guys to be out of there in 3 days. And we're focusing our volunteers on 24/18, where those dogs will be in there for 10 days. Sometimes it's hard for volunteers to keep protocols straight and keep rooms straight when you have a whole bunch of rooms, different rooms in a shelter. And so for clarity and reducing confusion, we've just kept them into 24/18 for now. And it's allowed us to save way more lives. But what we have learned is don't get careless with puppies who have positive titers. And I think even when they go to Maddie's, they're still in a room where anyone who's handling needs to wear gowns. And they're not around other puppies So we are managing it on Maddie's end, but we still don't want them to be breaking with Parvo over there. And I think that, talking about how to use the data is really interesting. You could use it. Well, we thought we could use it initially by targeting transfers by source. We still can on some level. Time of year, we see a seasonality and just some really cursory look at the data as far as what time of year are we seeing these Titer positive animals come in. So you could actually use the data to target transfers based on that. We also know which one of these transfer partners have more cases of Parvo that are coming in. Like, for example, Merced has, out of our Parvo cases, the majority of them or more of them have come from Merced than from Stockton or San Francisco. So you could use that in targeting your transfer program as well. And puppy enrichment for us continues to be a priority. We're so fortunate to have Dr. Janine Berger, who's our board-certified veterinary behaviorist, on staff now. And she works private practice in the hospital a couple days a week, but she works with our shelter animals for 2 days a week as well. And her behavior team right now are actually, they're one of their priorities is working on improving our enrichment and socialization program for the puppies that are in quarantine. So not just the ones that are in 24/18 for the healthy quarantine, but what if Parvo breaks and they're in there for 14 days? Or how do we improve our socialization of even the guys that are in 24/12 or 24/16? So what we've done in the past, we have a great volunteer program where they go in and they visit. But there's, we believe that there's more that you can do than just visit an animal. You can target your visit to have socialization and environmental enrichment and have all sorts of olfactory and tactile stimulation. And so they're working on those sort of things, and we're really close to getting a protocol in those rooms right now. So that's our program, and so far it's been really good. It's been great, and who doesn't love puppies?
Awesome. Well, that wraps up Parvo Monday.
I think Aaron Rodgers would be very happy if he knew.
Yeah, we got you a puppy. So thanks, everyone. Thank
you so much, Dr. Kate, for participation. You guys are awesome.
Thank you. Thank you for your awesomeness in planting the seed. It's been great.
Hey, Kate, you wouldn't happen to need any puppies from Florida or the Southeast in general, would you? We'll do the Titers for you prior to shipment if you like.
I'll keep that in mind. I will. Never say never.
Yep.